She says thank you. Because it would take too long. And by the way, there will be opportunity for questions at the end, and I will run around like Phyllis Donahue, making sure everybody can be heard. But Dr. Herbst, most of all, has put her passion into her profession, and her brilliance is only matched by her heart for people. And so without further ado, Dr. Karen Herbst.
I gotta stop crying. So I want to thank Lymphopress for this celebration this morning. We were denied really a celebration together because of the pandemic. So this is really nice to have here, especially at the ADLS. And I really want to thank Amzar and Brenda for your support throughout the years and for the celebration. So I'm going to represent the authors of the standard of care. It was by no means just me. This was definitely a collaborative effort, and we all felt that lipedema still remains a misunderstood disease and even a forgotten disease, because it was initially described in 1940 at the Mayo Clinic here in the US. But many other countries had a standard of care, but we did not. And in fact, in Germany, they have accepted lipedema for a long time, but it's not been as accepted here in the US. And in fact, many women are misdiagnosed as having lifestyle-induced obesity, lymphedema, or even fibromyalgia, because lipedema tissue is painful. So now we have a standard of care. We published it in the Journal of Phlebology this year in June, and that was Lipedema Awareness Month, so the coincidence of that was could not be denied. And again, it was a complete collaborative effort, and the authors are all listed here. So what is the history of how this consensus document came about? Well, we've talked about it for years and years and years. And so in 2018, I wrote an NIH conference grant, and it was approved in 2019, just before the meeting at the Fat Disorders Resource Society. And we were waiting on it. And I remember Steve emailing me like, are we funded yet? And I'm like, not yet, we should just go ahead. So we all decided no matter what, we were gonna go ahead, but luckily we did get funded. And this is one of only 2 grants at the NIH that have lipedema in that. So the NIH needs to fund more research on lipedema, not just these 2 grants. But one of them is actually to Shelley Krasinski and Paula Donahue at Vanderbilt, so very exciting. So so I put together 96 statements of lipedema, just from the literature and just from us all talking together. And everyone completed a questionnaire on these statements. They rated it, and we then averaged the answers and then presented and discussed it at the conference. Steve Dean and John Bartholomew presented standard of care guidelines from different countries. Michael Schwartz presented surgical talk, and we discussed everything about lipedema. We went hog wild. We had papers flying and slides flying and notes and discussion, and we whittled it down to about 90 statements. Consensus is defined as greater than 75% agreement on statements. We had much more than that. It was the most collegial large group that I have ever worked in. And we had a parliamentarian with us just to keep us under control unless somebody went rogue. And that never happened. And I think she whispered a few words to me during the entire conference, and that was it. Once we went through the round and had 90 statements, we started writing, and we passed out the different sections to the different groups. So the therapists wrote their section. Steve and Jerry wrote their section on arterials. Lindy and Tom wrote their section on veins. Nick Pennings and I wrote our section on medicine. And then we piled it all together and we handed it out to everyone. It was reviewed again. Some of the statements weren't in full agreement, so we changed them and we ended up with 85 statements. I'm definitely not going through all of those today. These are the different sections of the paper, and you should all have access to a copy. The introduction and methods, of course, but a lipedema overview where we talk about what we think might be going on in the pathophysiology. And we may not be right, but we hope that it generates discussion. We talked about medical treatment, conservative and other therapies, surgical treatment, and arterial and venous disorders that are present in lipedema. So it's a great reference article if you have a question about lipedema, what other people in the field think. We graded it too. We graded it either with a strong or weak recommendation, so a +1 or a +2. That's not exactly right. I probably would have done it differently, but I still think it is helpful to you as a reader. And then how good is the evidence in the literature? So we graded it as grade A, high, E, moderate, or C. And then here's a picture of our stages of lipedema, and you can see that as the stage number increases, that there's more fibrosis in the tissue. And you can see that by the deformations in the skin and the underlying connective tissue. And oftentimes this is associated with pain, and the pain has been shown, at least in one study, to be greater than that than for people with lymphedema. So this is our first consensus statement in the standard of care article. Lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes. And we had had a full day at standard of care meeting. We were in the restaurant bar, and we were all sitting around talking about what was going on. And I thought to myself, what is the definition of fat? Like, how could I define that? So I got my phone out and I looked it up, and up popped loose connective tissue. And I thought, oh my God, this is a loose connective tissue disease. And I remember clearly Steve Dean saying, if we get anything out of this conference, if we just get that, then we've accomplished a lot. And this shows where loose connective tissue fits amongst all the connective tissue types. But if you delve a little bit deeper into the literature, you'll find adipose tissue described as loose connective tissue, specialized connective tissue, or unique connective tissue. So I think we should all agree that adipose tissue is connective tissue. And it's definitely different from the tendons or ligaments, but connective tissues working together define fascia. And fascia has about 7 times more pain receptors than muscle. So perhaps the lipedema pain could be secondary to inflammation of the fascia in the heart. And I think this slide is going to really drive home the point that it has to be a connective tissue to survive. So postnatal adipocytes have to come from somewhere. And yes, they can come from stem cells that derive from bone marrow, but it's been shown in numerous publications that pre-adipocytes come from vascular stromal cells, endothelial cells, and even superficial fascia or connective tissue. So fat tissue is not just adipocytes, it relies on the connective tissue structure around it in order to repair and expand and remain viable. And I think it's important to view it as a connective tissue because it helps us better understand the physiology of lipedema. And again, we don't have all the answers, but there are 2 parts to connective tissues. There's the cells, and then there's the area outside the cells, or the extracellular matrix components. And those extracellular matrix components include fibers, like collagen and elastin, and proteoglycans, which are a protein backbone to which glycosaminoglycans are bound, like a tree branches. And glycosaminoglycans are repeating disaccharide sugars. Those sugars are negatively charged, and they bind up water and sodium, except for hyaluronin. Hyaluronin is a very specific glycosaminoglycan that doesn't have a negative charge, and instead it binds to the protein backbones of proteoglycans, forming a huge proteoglycan complex. So you've got your sugars, your proteins, your sodium in your water, and what does that form? A gel. And in the extracellular matrix, that gel is in equilibrium with free fluid. There are also glycoproteins and then the free fluid. So fluid can exist in 2 states in tissue, either free or bound. And we heard Dr. O'Donnell's talk yesterday. It's so dry here. And he said that most of the fluid within tissue, or the greater percentage of fluid in the tissue is present bound. Well, where is it bound? Here is one main location for fluid to be bound. And when you look at women with lipedema, their hands and feet are unaffected, which is different from lymphedema. Why is that? Could it be that that fluid is bound up in the gel so it doesn't trickle down to the hands and feet? And if you've ever felt lipedema tissue, especially in the later stages, it's really heavy. Or if you ever hold a plate of Jell-O, it's really heavy. It may be that this proteoglycan gel in lipedema has expanded so much that it's now heavy, and we're feeling that in the tissue, but it's holding on to its fluid and not letting it move. So this is kind of a schematic diagram of connective tissue. So you've got your small vessels, which include capillaries and venules, and I do believe that venules play a role in the pathophysiology of lipedema. We've shown that these small vessels are dilated. We and others, actually, not just us, but we and others have shown that capillaries are dilated in lipedema tissue, and this could be because of a mutation in the connective tissue itself, which makes it weak, or it could be due to inflammation and loss of that glycocalyx, which is one of Mark Boeing's babies. However you get there, if you've got a dilated small vessel, it releases increased fluid into that interstitial space, and it gets bound up with these proteoglycans, in addition to sodium. And the fibroblast here holds the structure of the extracellular matrix so that it doesn't expand, and any fluid that enters should be pushed right out through the lymphatic vessels. But in the presence of excess fluid or inflammation, these fibroblasts release their hold on the structure, and the proteoglycans increase. So anytime there's fluid overload, proteoglycans will increase and bind up the water and sodium. So fat actually acts as a storage area, not just for triglycerides, but also for water and sodium. And when the fluid goes back down, the proteoglycans release their water and potentially their sodium, and then the proteoglycan levels decrease down in the tissue. And it may be in lipedema that the type of proteoglycans, and there are many different types due to the glycosaminoglycans that bind, they may be different in lipedema than in tissue that is not lipedema. And if this area expands, it's going to move these adipocytes further away from their oxygen source, or those microvessels, resulting in more inflammation, and inflammation decreases lymphatic pumping, and the whole cycle starts again. And I've been talking about lipedema tissue as compliant for years. I didn't even really know what I was saying, but I said, there's something about the tissue, it just expands and it says, okay, I'll take more fat, and more fluid, and more fat, and more fluid. Well, I started reading Guyton's textbook of biochemistry and physiology, and that was actually republished here by Babe and Nielsen. And what the concept is that here on the y-axis, you've got interstitial pressure, and then on the x-axis, you have interstitial fluid volume. And as Mark Moline mentioned last night, there is a negative pressure in tissue. The minute fluid enters, the pressure increases dramatically and pushes that fluid right out of the tissue into the lymphatic vessels, and the tissue stays healthy. But if you have too much fluid and you pass euvolemia, those fibroblasts release the fibers in the tissue, and the tissue then becomes very compliant, and it will take in fluid without increasing pressure anymore. And it just grows and grows over time if the fibroblasts are not able to reform that structure and bring that pressure back down. So inflammation releases the structure, allowing proteoglycan complexes to expand. And I think women with lipedema live in this state with an expanded proteoglycan gel throughout their tissue. This is not really breakfast pictures, but I've talked about inflammation in lipedema tissue. Fibrosis follows inflammation, and we think that fibrosis is not only in the extracellular matrix by definition, but also the fibers become thickened in the tissue. And I've had the benefit of working with Dr. Jamie Schwartz, who's a plastic surgeon and does a lot of work with lipedema liposuction. And he lets me come in the OR and look at the tissue and feel the tissue. And the fibers are so firm, you cannot even get your finger past maybe a centimeter of the opening for the cannulas for the liposuction. And he opened this area a little bit more so I could see, and you can see these two nodules here. So when we palpate lipedema tissue, we feel nodules. And so we pulled these nodules out and they're hard. And when he removes those by liposuction, you can see the nodules are white here because they're very fibrotic. So the fibrosis is in two different areas in the tissue, and whether that's all by one inflammatory source, I'm not exactly sure. So because we're at the AVLS, I think it's important to talk about vascular disease. And the arterial part of this document was written by Steve Dean and Jerry Bartholomew. And when you see a woman with lipedema, she's got pain. And I would love to stress that we shouldn't just assume, oh, you have lipedema pain, and I'm just going to leave you alone with your lipedema pain and you can go get your liposuction or wear your compression. Because pain can come from arterial disease, from venous disease, or from the lipedema tissue. So don't forget to assess the arterial portion of your physical exam. Because I've got patients with lipedema who've lived with metabolic disease for many, many years, in addition to increased lipedema tissue, and they've ended up with arterial disease. But if I just assumed it was their veins or I assumed it was their lipedema tissue, they wouldn't have gotten the treatment that they needed. So if you do suspect arterial disease, a great way is just to check pulses. You're going to look at them by an ankle brachial index, just as you would anybody else with arterial disease. That's what we recommend. There's also a lot of venous disease in lipedema. Steve Dean published this last year, is that right, 2020? Showing that at least, and probably more than 50% of women who have advanced stages of lipedema and lymphedema have some sort of venous disease. And this includes an increased risk for venous thromboembolism, varicose veins, chronic venous insufficiency, and telangiectasias. So when you see your patient with lipedema, you examine the arterial side. You're also going to examine her risk for venous thromboembolic event, especially if she's undergoing knee surgery or lipedema reduction surgery and liposuction, and just follow regular guidelines. How do you evaluate venous disease in lipedema? So this part was written primarily by Lindy McCutcheon and Tom Wright. So chronic venous disease can present with leg swelling and pain and should be considered in the differential diagnosis of lipedema. So they can have both venous pain and lipedema pain. And we don't really even understand lipedema pain, like where is it exactly coming from? We think that women should be evaluated using the CEAP criteria, just like you would for another patient who had venous disease. And we also recommend a venous duplex ultrasound to assess for clot, to assess for obstructive flow, but also to assess for varicosities and for venous insufficiency. And believe it or not, there is not one good study on veins, a prospective study on veins in women with lipedema. There's no studies on treatment of veins for patients with lipedema. And I know there's a research symposium today, like how to get research going in your clinics. And since there's a lot of people that are working on veins, and I'm sure you see patients with lipedema, I would love to see more efforts in this area.